Now we are going to talk about the prisms. So prisms is like a crucial topic in optics because almost everything that is coming later on is dependent on your understanding of prisms. Various ophthalmic instruments and also there are some basics in the geometrical optics and the human optics will be dependent on understanding a proper understanding of the prism. So I hope that you will be able to have a clear ideas about the concepts of prisms, and let's start. So what is a prism? A prism is a part of a refractive medium that is bounded by the two surfaces that are inclined at a definite or a finite angle. So if we have this part, this triangle is taken from a refractive medium, like for example for a glass, and this medium has two surfaces like this, and these two surfaces are joined together with an angle, then this is called a prism. So this is just the basic definition of a prism, and this is what is a prism. And as we used now, so we will know the anatomy of the prism, what is the structure of the prism, and what is the basic terminology of the prism. So here we have the prism. Usually the prism is referred as or drawn as a triangle. So this triangle is formed from three limbs. As you can see that the incident ray will fall at one surface. So this is called a refractive surface. Every prism has two refractive surfaces. These refractive surfaces are joined together, as we said in the definition, by an angle. This angle is called the apical angle, or angle alpha, or the refractive angle. Again, the prism has two refractive surfaces. These refractive surfaces are joined together at the angle, at the apex by an angle. This angle is called the apical angle, or the refractive angle, or the angle alpha. There is an axis that bisects the refractive angle. So the axis of the prism is the line that bisects the refractive angle. And the base of the prism is the bottom, or the side opposite the apex, or the side opposite the apical angle. And we use this base for orientation. So for example, we say that this prism is base up or base down, or base in or base out. So the orientation of the prism is referred by the direction of base. So here we have the prism. Here there is an incident light ray that enter one refractive surface that undergoes refraction, then it will emerge from the other refractive surface, and then it undergoes deviation. So this is the basic benefit or basic rule of the principle of the prism, that it causes the light rays to deviate. So when there is an incident light ray, it should pass in the straight line, and this will be the original direction of the ray. But as it goes through the prism, it undergoes refraction, and it will be deviated like this. So how can, or what is the rules that govern the refraction by prisms? So if we have, this is a prism, as we said, the angle between the two refractive surfaces is called the angle alpha, or the apical angle, or the refractive angle. So we have an incident light rays that undergoes refraction from less dense to the more dense, so it undergoes refraction toward the normal. Then it will undergoes refraction from the prism to the air interface. So it will be from the more dense to the less dense, so it will undergo refraction away from the normal. So the incident rays will undergo the refraction by the prism, and the emergent ray will be always toward the base. This is very important. So the emergent ray is always toward the base. If we extend the light ray from the incident and the emergent light rays, they will both meet an angle. This angle is called the angle of deviation. So the incident light rays should pass in the straight line. However, it is now deviated to this light ray, the emergent light ray, which is now deviated toward the base. So it was meant to pass through the apex or toward the apex, but as it goes through the prism, it is now deviated toward the base. This angle of deviation is the angle between the incident and the emergent rays. This angle equals the refractive index of the prism minus 1 multiplied by the alpha. So if we obey the Snell's law of refraction, so the light passing through the prism will be deviated toward the base, as it will pass from the more dense to less dense, so it will be deviated outside or away from the normal. Angle of deviation equals d. So the d, which is the angle of deviation, equals the refractive index of the material of the prism subtracted from it 1, and then all of this will be multiplied by alpha. So n is equal for refractive index. Refractive alpha is the refractive angle, and if we use a prism in which the refractive index prism made of glass, so the refractive index will be 1.5. So the angle of deviation will equal 1.5 minus 1, so it will be equal 0.5 multiplied by alpha. So the angle of deviation equals alpha divided by 2. So this is the first rule in refraction by prism, that the angle of deviation, that sometimes called the angle of minimal deviation, equals the half of the apical angle, or the apical angle is equal double of the angle of deviation. This is very, very important. As I told you, the factors are always important. So what are the factors that are responsible for the angle of deviation? First of all, we said when we were talking about the dispersion, we said that the wavelength is important because the angle of minimum deviation is smaller for longer wavelength. So we said that the red light is deviated by a little angle or a smaller angle than the blue light. So this is because the red light has longer wavelength and smaller energy, and the bluer light has a shorter wavelength and higher energy. So the longer wavelength, the little or the less angle of deviation. The second factor will be the refractive index. So the material of the prism has an important rule, as we say that when the refractive index is 1.5, then the minimal angle of deviation will be equal the apical angle divided by 2. So what happens if we increase the refractive index? So the angle of deviation will increase. The angle of the prism is directly proportionate again. So if we increase the alpha, the d will increase. And finally, the angle of incidence. So all these factors are responsible for the amount of deviation by light rays as it enters through the prism. We have two common prisms or two common materials that make up the prisms in ophthalmology. So we have the plastic prisms and we have the glass prisms, and the amount of deviation of each one of them is different according to in which position it is held in front of the face. The two most common positions, one is called the Prentice position and the other is called the minimal angle of deviation position. So what is the Prentice and what is the minimal angle of deviation? The Prentice position is the one that we use in case of glass prisms. So if we are using, you will see that there are some thick lenses inside the trial lens frame, and these are the glass prisms. These glass prisms, when it is placed in the trial frame, their posterior surface is perpendicular to the visual axis. And this is what's called the Prentice position. So again, the Prentice position, the prism, the posterior surface of the prism is placed perpendicular to the visual axis. So a famous example for this is the glass prism of the trial lens frame. The problem with the Prentice position, that if we have a small error or smaller deviation from this position, this will lead to large deviation of the angle. meaning that if we have 40 prism diopters of Prentice of a prism that is held in the Prentice position, actually the deviation of this prism is not 40, it is only 32. So this prism is not much accurate. So we use it in the trial lens frame, but we don't depend on it for measuring the angle of squint. The second position is called the position of minimal angle deviation. In the position of minimal angle deviation, that is what we use when we are using the plastic prisms. So the plastic prism, like a prism bar, like here, this is the one that we use in case of examination of a squint case. And in such a condition, the posterior surface of the prism is held parallel to the frontal plane. So here is the frontal plane, and here is the prism. The posterior surface of the prism is held parallel to the frontal plane. In such a condition, a small error will lead to only minimal deviation. So, for example, if the patient has 30 prism diopter and we put a 35 prism diopter, this will not cause much troubles or much difference if we compare the two, if we put the prism in the Prentice position. So here are the two main positions, the Prentice and the angle of minimal deviation position. Let's now talk about the characters of image. So as we go through the optics, it's important to know the characters of image produced by any tool or any surface, refracting or reflecting surface that we use along our study. So if we have a prism, and what are the characters of images produced by this prism? So here we have an object, and this object will emerge light rays that will go through the prism, undergoes refraction, and then it will bend again and undergoes refraction as an emergent ray bending toward the base. So first rule here is that the light rays is directed always toward the base. So if my eyes are here on the opposite side of the prism, how or where shall I see the image? As we know that we cannot see in bended lines, so we always see in straight lines. So I can see now a light rays will enter inside the eye, so I will see a virtual image along the direction of the emergent light rays. So I will see a virtual image. This virtual image is displaced toward the apex. So when I put the prism in front of my eye, the light rays coming from the object will be directed toward the base, but the object itself, or the image, and my eye consequently will move toward the apex. Again, so this is the object and this is the image. Again, if I have a prism in front of my eyes and this is the object, now the light rays will be refracted toward the base, so there will be an image that is formed toward the apex. So my eye will move toward the apex. This is a crucial rule for understanding the prism. Again and again and again, light rays will refract toward the base. The eye and the image will move toward the apex. Prism chromatic dispersion, we have been discussing it already in the previous lecture. Just to say, a quick reminder that if the light ray passes through the prism, the shorter wavelength will undergo refraction more than the longer wavelength, leading to dispersion of the white light into the spectrum of colors. Another important hint here that is frequently asked in the exams, that the dispersive power of the prism is not related to the refractive index of the prism. This is very important. The dispersive power of the prism is not related to the refractive index of the prism. Okay, what happens if we add two prisms together? This will depend mainly on the orientation. If I'm putting a prism base to the prism apex, or if I'm putting the apex to apex and base to base. If I'm putting a prism base to apex and both of prisms are of equal power, then the light reflected by or the light refracted by one prism will be neutralized by the light refracted by the other prism. So the prisms will act as a parallel plate of glass, as we said in the previous lecture. So the image will just be laterally displaced, but the direction of the image will not change. If they have unequal power, so the net result of the light rays will be equal to the summation of both. So they will be the stronger prism will be the more effective prism. So this prism will cause deviation of the light rays downward, and this prism will cause deviation of the light upward. So the net result will be according to or the emergent ray, the position will be according to the stronger prism. This is very important, or combination of the prisms are important in refraction in case of using the lenses or what's called doublet lenses. So when we will talk about the chromatic aberrations, we will say that when the light entering inside the prism, it will undergo dispersion. So this dispersion is called the chromatic aberration, and it will be responsible for chromatic aberrations of the lenses. That's why the lenses are the professional lenses like we use in ophthalmology, like 90 diopter lenses, or the indirect ophthalmoscopy lenses, or the lenses used in photography are used a combination of prisms or combination of lenses that has prismatic effect that we will talk about later, and this will lead to elimination of dispersion. So when the light enter in one prism undergo dispersion, the other prism will be on the reverse position so that it can combine this dispersed light and it will emerge as white light. Also, prism can be put together apex to apex. So in this condition, the net result of both prisms will be the summation of the power of both prisms. Now let's talk about the notation of prism. Notation meaning that how do we name the prism? How do we name the power of the prism? So the power of the prism is meaning that, or it is representing the amount of light deviation produced by the prism. If we have a powerful prism, it will cause much more deviation of light. If it is a weak prism, it will cause less deviation of light. So how can we calculate this amount of deviation? This can be done by four methods. The first one is called the prism diopter, and it can be referred as an invert empty triangle, as you can see here. So what is a prism diopter? So if we have a prism that its power one prism diopter, this means that this prism has the capacity or has the ability to deviate the light for of an object placed at 1 meter for 1 centimeter. Meaning that it is if there is an object placed at 1 meter from this prism, and now this prism can deviate the image of this object by about 1 centimeter along the straight line. This is called a prism which has a power of 1 prism diopter. Another method for nomenclature or notation of the prism is called the centrode. Centrode is referred as an inverted blank triangle or inverted white triangle, which is usually slightly more than 1 prism diopter. So what is one centrode? Again, if we place an object at a distance of 1 meter, and this object will emerge light rays from the prism which has a power of 1 centrode, and then it reaches the eye, then we can see the image of this object which is displaced about 1 centimeter again, but it is not along a straight line, it will be along an arc. So let's make the pen. Here we are. So what happens if we have a prism diopter here of 2 prism diopters. So this will be, the image will be like here. And if it's 3 prism diopter, will be like here. 4 prism diopter, the image will be like here. So this is called the prism diopter. But in case of the centrod, if they have a prism of 2 centrod, then the object, or the object, if the object is placed here, then the image will be of 1 centrod will be like here. The second of 2 centrod will be like here. 3 centrod will be like here. 4 centrod will be like here. So there will be a displacement of the image, but it is not along the straight line. It will be along the arc. So this is what's called bicentroid. We can also refer to the prism diopter power by the apical angle, or angle alpha, or we can refer by angle of minimal deviation. So this can be like this, and this is like this, and this is the minimal angle of deviation. So is there any relation that will control all these notation methods? Yes. So practically speaking, the 1 prism diopter will equal 1 centrod. But if this is for practice to make it easier. But for the academic knowledge, it is just the centrod. It is slightly more than the 1 prism diopter. But 1 prism diopter equals 1 centrod and equal 1 degree of angle of apical angle, and equal 2 degrees of angle of deviation. As we said, that the angle of deviation equals half of the apical angle, or the apical angle equals double the angle of deviation. So 1 degree of apical angle equals 2 degrees of the angle of deviation. So this is the rule, and we in notation or in practice, we use the prism diopter and we use the angle of deviation. So 1 prism diopter equals 2 degrees of angle of deviation. So always the angle of deviation is half the prism power, or prismatic power of the prism. Let's now talk about the clinical use of the prism. Why do we use prisms? We use prisms for different purposes. First of all, it is used, or it is incorporated in different ophthalmic instruments. For example, the slit lamp, the keratometer, the tonometer, the telescopes. So different ophthalmic instruments use the prism for its ability to deviate light. And you just remember that we said that we use the right-angled prism and the Poro prism and the Dove prism in order to deviate the light and deviate the image. Also, it can be used for diagnostic purpose. For sometimes, if a patient who simulate blindness, or that he has or malingering, that we can detect by the use of the prism. Also, in preverbal children, if we want to know if the child can see or not, it will be by the same method, by placing prisms in front of his eyes and notice the movement or the fixation movement. Squint, the measurement of the angle of a squint can be done by the use of the prisms. Or we can use prisms for therapy or for treatment. For example, we use what's called exercising prism, relieving prism, hemianopic prisms, prismatic spectacles, and it can also it can be incorporated inside contact lens. So these are the main bulk of the lecture. So let's start. For the instruments, the prisms are used in different ophthalmic instruments, and we will not go through these because it has some specific lectures. So we will just postpone the instruments or the use of prisms in instruments to its right place. The second is the diagnostic. So what can we diagnose with the prism? First of all, it can diagnose simulated blindness or malingering and visual acuity in preverbal children. So how can this be done? By placing a prism in front of the seeing eye, this will lead to movement of the eye to regain fixation. And let's see this video in order to understand what does this mean. So here, this is a patient or a normal individual, so that we want to know if it can see or not. So this can be done by what's called 4 diopter prism base out test. So by placing a 4 diopter prism in front of one eye, and then we observe the biphasic corrective movement of the other eye. So what happens if we put a prism that is base out inside the right eye? Well, yeah, I think that you all said that the right rays will pass toward the base, while the image and the eye will move toward the apex, and this is the right. So if we put an image or put a prism base out in front of one eye, the whole scene in front of the patient eye will shift toward the apex or shift nasally toward the left side like this. So this will be movement, or there will be movement of the right eye toward the left, and by hearing law of equal innervation that we will discuss in the physiology, this will lead to movement of the other eye to also to the left side. So this what will happen. So what happens then? What happens then is that the left eye will regain, or the left eye, if it is seeing, the image of the left eye is not falling on the fovea because it is displaced now, it moved the temporal. So the left eye will regain its fixation, will try to fix again. And by this corrective movement, we know that the left eye is seeing, or the patient using the fovea of the left eye. So this is for a normal individual. So what happens if someone or another in the other patient that say that he is blind or he cannot see with his left eye? So again, we place the prism, the 4-diopter prism, in the front of the seeing eye and see the corrective movement of the left eye. So by placing the prism in the right eye, so the right eye will move to the apex, and the left eye will also move to the apex by the hearing law of equal innervation. So the medial rectus receives equal innervation like the lateral rectus of the left eye. So if the patient can see, then the left eye should show refixation movement. However, if the patient cannot show refixation movement of the left eye, then this means this eye is not seeing, or this eye is blind, or have foveal suppression of the left eye. So by using the prism, we have been able to see or to know if the patient is seeing or not. And by the same way, we can also detect if the child who is preverbal can see or not. The second thing, or the second use, or the second diagnostic use for the prisms are the squint. So what are the uses of the prism in squint? We can use the prism in squint for measurement of the angle of squint, so that we can know how much angle that we will work on surgery. We also use it for measurement of the amplitude of convergence and the measurement of the fusional reserve and the testing the binocular vision before the squint surgery. So I don't want to confuse you with too much irrelevant data, but we will say that the measurement of the angle we will see in the few slides, testing of the binocular vision before the squint surgery, meaning that if the patient will undergo squint surgery, so by squint surgery we do muscle surgery and we will change the direction of eyes. So we can anticipate, or we can expect the effect of the surgery before the surgery. This is by placing prisms in front of the patient eye. So for example, if the patient experienced diplopia, by putting the prisms in front of his eyes, then this will give us a clue that this patient will complain from diplopia after the surgery. For measurement of the amplitude of convergence and diffusion reserve, this is too much irrelevant data. But so we will come to the measurement of the angle of squint now, but we'll say just to complete, just to know what are the forms of the therapeutic lenses or forms of the therapeutic prisms. Well, let me change the organization a little bit. Here we are. Okay, so the second therapeutic use, which will be the measurement of the angle of squint. To have a basic knowledge about the squint, we have two types of squint or strabismus. We have the manifest strabismus, so you see the manifest deviation of the eye, or there is a latent strabismus. The latent strabismus is not evident all the time, but it is concealed or it is hidden, and it's only appear after if the patient is inattentive or if the patient is not concentrating, and you can provoke it with a specific tests. So the manifest squint can be measured or be detected by different tests like Hirschberg test, like Kremsky test, modified Kremsky test, and cover test. While the latent strabismus can be detected by the uncover test and the alternate cover tests and Maddox Road. So when the eyes are both aligned normally, they are called orthophoric. If the one eye is or any eye is more deviated downward, then this is called hypotropia. If it is elevated upward, this is called hypertropia. If it is deviated outside, this is called exotropia. If it is deviated inside, this is called esotropia. And by saying tropia, this means a manifest squint, while a latent squint it is called phoria. So hypophoria, meaning that there is a latent downward squint. Hyperphoria, meaning that there is latent upward squint. Exophoria, meaning that there is right latent squint. Esophoria, meaning that there is left latent squint. So the first test is called the Hirschberg test, and we have mentioned it already in the previous lecture, meaning that this is the corneal light reflex. So by projecting a pen torch in front of both eyes, this will lead to showing the central pupillary light reflex if the eye is perfectly aligned, or it can show deviation. And by this deviation, we can have a crude measure of the angle of squint. So it doesn't have any relation to the prisms, but this is just to complete the topic. So if the prism or the angle or the light reflex is present at the edge of the pupil, like here, then the angle of deviation is about 15 degrees. And by saying 15 degrees, this is the angle of deviation. So this will be equal half of the prism diopter of the corrective prism. So this means that this deviation is equal either 15 degrees or 30 prism diopters. If the light reflex is present between the edge of the pupil and the limbus, then this is called a 30 degrees of deviation or 60 prism diopters. If the light prism is looking out, or if the light reflex is present outside the limbus, so the angle of deviation is equal 45 degrees, or it is about 90 diopters. So now we know two information. We know the angle of a squint and we know the direction of squint. So the eye is now looking nasal, so it is esotropia. And by calculation of the location of the central light reflex, we will know what is the degree of squint. So let's have a quiz here. Would you please tell me in the chat box what is the degree of squint here and what is its direction? Yes, exactly. So this is a 30 degrees of exotropia of the left eye, or so it is equal to 60 prism diopters. The second test that uses the prisms is the Kremsky test. So the Kremsky test is, by this test, if we have a patient who have deviated eye, so we put a prism in which the base is directed against the deviation. So if we put the base against the deviation, like here, this is the base, looking the base is out and the eye is turned in, so we increase the prism power until we find that the pupillary light reflex is central in both eyes. So here this patient has an exotropia. So this patient has an exotropia, so the light reflex was located that was deviated inward. So we put a prism in front of his deviated eye, and we increase the prism diopter until we find that the central pupillary light reflex is central on the deviated eye. So here, this patient has a 50 degrees of exotropia, or 50 prism diopters of exotropia. Another test based on the Kremsky test, it's called the modified Kremsky test. So in case of modified Kremsky test, the prism is placed in front of the normal eye instead of the deviated eye. So this can be done in case of if the deviated eye is blind, so we can use the prism in front of the sound eye. And again, it can be used by the base against deviation. So here, if the deviation is inward, so we can use the prism outward, but so the base will be out, but it will be in front of the normal eye. So what happens when we do this? This will lead to corrective movement of the eye. So the right eye or the image will be displaced toward the base, while the light rays will be displaced toward the base, while the image and the eye will be displaced toward the apex. So this will lead to movement of the right eye nasally. So the right or to the left. So this will to the right of the image. So the left eye will be moving toward the right, so that the right eye will be moving to the left. And by increasing the power of the prism, this will lead to further movement of the left eye toward the right. Let me make it with the pen. It will be easier than, or less confusing. So putting the prisms with the base out in front of the sound eye or the left eye will cause movement toward the right. So the light reflexes start to be more central in the squinting eye. Increasing the prism diopter again will cause move of the both eyes by hearing law of equal innervation. So we increase the power of the prism until the light reflex is becoming central in the deviated eye. So this is what's called a modified Kremsky test. Prisms are placed in front of the sound eye with base against deviation until the corneal reflex in the squinting eye is normal. As you can see here, so the left eye showing esotropia. So we place the prism base out in front of the right eye until the light, and we increase its power until the light reflex is central in the left eye. So here we can use this is a practical application, how we use the prisms in order to diagnose squint and to measure the angle of squint. Other uses for, or the other methods for measurement of the angle of squint or detection of squint is called the cover test and uncover test and alternate cover test. So by cover test, meaning that it is used for detection of heterotropia or detection of manifest squint. So what happens, what is be done with the cover test? In case of cover test and we have a squinted eye, like the left eye, which is squinted outward, we cover the normal eye, or we cover the right eye as here. Then the left eye will be the only seeing eye, so it will take fixation, meaning that it will be fixing toward the object. So we will now, by movement of the left eye from outside to inside, in order to fix on the object, that this left eye has exotropia. The reverse occur with the uncover test. So the uncover test, it is used to detect heterophoria or detect the latent squint. This can be done by covering any one of both eyes. So by uncover the eye, this will lead to appearance of deviation. So both eyes are perfectly aligned in the primary position, and by just covering one eye, leading to breaking of the binocular fusion of both eyes, this will lead to appearance of a deviation of the eye under cover. So in case of cover, we cover one eye and look to the other eye, while in the uncover, we cover one eye and look for the same eye immediately after removing the cover. If it shows any movement, then this eye has heterophoria. Alternate cover test is used to measure the total deviation. So if we have a patient who has both exophoria, or have heterophoria and heterotropia, we can rapidly alternate the cover between both eyes, and so any corrective movement to maintain fixation on the target, and this can calculate the both phoria and tropia. So what concerns us here is the use of the prism. So we can use the prism in conjunction with the cover test in order to calculate the amount of deviation. So this one test is called the prism cover test, or the simultaneous prism cover test, in which we simultaneously put the cover in front of the sound eye, and we put the prism in front of the deviating eye. So by removing the cover and putting the cover again, this will lead to a corrective movement or fixation movement in both eyes. So we increase the power of the prism in front of the squinting eye, and until there is no movement of both eyes occur. So if there is still movement while we are changing the position or increasing the power of the prism power, this means that we didn't reach the final prismatic power of the deviation. As a rule, always the prism is placed with the base against the deviation. So you can consider the apex of the prism like an arrow. This arrow will point always to the fixation, or point always toward the deviation. But in practice or in the exam, we always name the prism by the base, as we said. So here is in case of esotropia, we use a base out prism. In exotropia, we use a base in prism. In hypertropia, we use a base down, and in hypotropia, we use a base up. So we now know the technique, and we know how we orient the prism. Another test that use the cover test in association with the prism bar is called the alternate prism cover test. So the alternate prism cover test, in which the prism is placed before one eye with the base against deviation. So as we said, the prism will be placed in front of the squinting eye with the base against deviation, but in this condition we will alternate the cover between both eyes, not placing the cover always in one eye. So by changing the cover between the right eye and the left eye, then we will be able to calculate the total amount of deviation, both the latent or the phoria and the manifest or the tropia. So we switch the cover between both eyes, and if there is movement, we increase the power of the trial lens frame until there is no movement at all. Another application of the prisms is called the Maddox rod. So what is the Maddox rod? Maddox rod is a lens that consists of a series of powerful convex cylinders. So this cylinder and this cylinder and this another cylinder, both of them join together, and this is about the power of each one of them is about 150 diopters. So this will be discussed in the cylindrical lenses. The value of this Maddox rod, that when a light is seen through this Maddox rod, it will be converted to a line. Okay, so the Maddox rod will be converted the dot into a red line. That is, this line is made by each cylinder. So each cylinder will focus the white dot into a focus. The connection between all foci of these positive cylinders are making a line. So this line is perpendicular to the axis of the Maddox rod. So for example, if we are placing this Maddox rod in front of the right eye with the cylinder in the vertical direction, this child will be able to see a horizontal line with his right eye. So this is called a dissociative eye test. There are different dissociative eye tests. One of them we have already mentioned, which is the uncover test or the alternate cover test. So we dissociate the binocular movement, and by mean dissociation, we mean that we make the right eye see an image different from the left eye. So this is a dissociative eye test that makes the left eye see a white spot, and the right eye see a line. So why do we see this, or why do we make the patient see this? This is in order to detect the heterophoria. So as we said, the heterophoria or the latent squint is a problem that can be corrected by the brain in the process of binocular vision. So if the patient has binocular vision, he has binocular fusion. So he can fuse the image between the right eye and the left eye, and can compensate and control the heterophoria. If we wanted to reveal this heterophoria, we need to dissociate both eyes. So we can make the right eye see one image and the left eye see another image. So what happens if we ask the patient to look at the white spot in the wall with a right eye, with one eye that has no lens, and Maddox rod is placed in front of the other eye. So if we put a Maddox rod which is in the horizontal meridian in the right eye, and the left eye doesn't have any lenses at all. So the left eye should see a white spot, and the right eye should see a vertical red line. So if both the red line and the white dot are coincidental, or they are coincide, this means that this patient doesn't have horizontal phoria. But if they are displaced at one side, so the patient can see white dot at one side and red line in the other side, so this patient can have either exophoria or esophoria. And by changing the direction of the Maddox rod, making it the cylinders are vertical, so the patient can see a horizontal line with this eye. So if this horizontal line is above or below the white dot, then this means that the patient has hyperphoria or hypophoria. So this can be a test just to know if the patient has a heterophoria or not. And please note that this is the Maddox rod value that it can detect heterophoria for far. However, we have another device that's called Maddox wing that can detect the heterophoria for near. So if the red streak seen by the right eye cannot be fused with the white spot seen by the left eye, then the prisms of increasing power are added in front of the right eye till the red streak and the white spot are fused. This is the rule of the prism here. So if there is no fusion between the white spot and the red line, then we will place prisms in front of the right eye until the patients report that this prism and this white line are on the same plane. So that, and by measuring this amount of prism, we know how much prism diopter does this patient have of heterophoria. And please note that the eye behind the Maddox rod is always deviated against the direction of the red line. That's why in case of the right eye, the exophoria, the red line will be deviated nasally, and in case of esophoria, the red line will be deviated temporally. Also, another use of the Maddox rod is called the double Maddox rod. And the double Maddox rod is used by placing a Maddox rod in front of the right eye and another Maddox rod in front of the left eye. They are of different color. So the right eye will be having a right Maddox rod, and the left eye will have a green Maddox rod. So this can be used to detect what's called torsion, angle of torsion. You remember when we said in the anatomy of the extraocular muscle that there is what's called cyclotorsion. So there is intorsion and extorsion. In some conditions, there may be a paralysis of one or more of extraocular muscle that will lead to torsional diplopia. So the patient see the images are oblique. In order to measure this torsional effect or the cyclotorsion, we place the Maddox rod in front, two different Maddox rod in front of both eyes. So the right eye should see a red line, and the left eye should see a green line. Both lines should be parallel. But if the patient cannot see them parallel, what we will so the patient should see both lines like parallel like this. But if the patient cannot see them parallel, then this means that this patient has encyclotorsion or excyclotortion. Then we will ask the patient to rotate the knob at the sidebar of the term of the trial lens frame until both lines coincide. So if the patient, for example, say that one line is deviated, then we will ask the patient to rotate the knob until the both lines are parallel again, and we calculate how much does this Maddox rod, or how much the patient rotated his Maddox rod, and then this is the angle or the degree of cyclotorsion. Then these are the diagnostic values of the prisms. So we'll now come to the therapeutic values of the prisms. How do we use the prisms for treatment? We use the prisms in different ways in order to treat the squint. First of all, if we have we have what's called exercising prism. So imagine the prism like a working gym or workout for the muscles. So this exercising prism will train or will improve the function of the weak muscles. In such a condition of the exercising prism, the base is made with deviation. So how can we do this? If the patient has convergence insufficiency, so his both eyes cannot turn inward, what can we do? We can place a prism in front of both eyes in which the base is out. So what happens if we place base out prisms in front of both eyes? When there is an image or there is an object that will project light rays, this light ray will deviate toward the base and the image will be deviated to the apex. So both eyes and the image will be deviated toward the apex. So the eyes will deviate toward the apex, which are located nasally, so that we train the medial rectus here and the medial rectus here to converge or to contract, leading to convergence. So we improve the convergency by training the medial recti or by exercising the medial recti to look inward. So this will be the same thing when the patient has exophoria. So when the patient has exophoria, meaning that the eye are deviated outward, so we place a prism base out so that we train the eye to look inward so that it can control the exophoria. The esophoria, the reverse will occur. So if the eyes are looking inward and we want the eye to be more aligned in the primary position, so we put prisms base in like here. The image will be displaced toward the eyes will be displaced and the image will be displaced toward the apex. So the image will be like here. That's how we can control this esophoria. So we force or we exercise the eye to look outward so that it can be aligned in the primary position and to correct this esophoria. So exercising prisms usually or they are used for cases in which the muscles are functioning well and they are just a little bit weak, but not if they are restricted or if they are paralyzed. If the muscles are restricted or they are paralyzed, then we use what's called relieving prism. In relieving prism, we use the base against deviation. Not with deviation, this is the key word here, but the base will be against the deviation. Meaning that if the patient has paralytic or restrictive squint, for example, if the patient has hyper or hypophoria or tropia due to paralysis or restriction, then let's say this is hypertropia or hypotropia, not hyper and hypophoria. Let me just correct it. So if we have a hypertropic eye, let's say, for example, if the patient has a fourth nerve palsy, so this hypertropic eye cannot be decreased down. So I cannot train this eye to descend downward. But the other easy solution is to bring the image upward. So how can we bring the image upward? It is by placing a prism base down. So if I place prism base down, then the object light rays will pass through the prism and now it will deviate toward the base. So the patient will see the image will be displaced toward the apex and the eye as well will be displaced toward the apex. So the eye is already hypertropic, so it can see the image which is present high. This is because I placed a prism base down in front of the hypertropic eye. The same occurs with the hypotropic eye. So for the hypertropia, if the eye is, for example, a patient has a third nerve palsy and the eye is looking down, so I can't move the eye in the upward position so that I bring the image down. So if they have an object and this object will project light rays that will pass toward the base of the prism, and then both the eye and the image will pass toward the apex, so that the image will be placed toward the apex of the prism, which will be downward, so that the patient will be able to see the image without diplopia. Also, the relieving prism can be done in older presbyopes who are not be able to converge by placing a base in prism and decentration. We will postpone this when we were talking about the decentration, so you will be able to understand this. Hemianopic glasses, for example, if the patient has hemianopia, so this patient who has hemianopia, this patient cannot see one blind hemifield. So this patient who has right homonymous hemianopia cannot see the temporal field of the right eye and cannot see the nasal field of the right eye. So what can we do for these patients? Theoretically speaking, we can give them glasses that can deviate the light rays that is falling toward the blind retina toward the other seeing retina. So this is doubtful that it works, because the working part will be confused from both images. But just know that in case of hemianopic glasses, we put the base toward the blind side. So here we put the base like this. So the base will be out, and in the left eye, the base will be in. So by putting the base out right eye, base in left eye, this can be a treatment for the hemianopia by putting the base toward the blind side. Other forms, or the forms of the therapeutic lens, they can take different forms. So we said the uses of the therapeutic lenses. So how can we use them? This can be done by either temporary prisms or permanent prisms. So temporary prisms can be used if the condition is changing. For example, the angle of squint is changing all the time. So the famous example of the temporary prism is called the Fresnel prism. It is Fresnel, not Fresnel. The Fresnel prism is a sheet of prism that is placed at the back of the glasses. So it consists of series of small prisms that acts together like a single large prism. Or if we have a permanent problem, then we can use a permanent prism, like for example in all the presbyopes. So here we can see this is the base of the prism and this is the apex of the prism. Other types of the prism, there is the single loose prism, like here, that we can use for the measurement of the angle of squint, and we have the prism bar. So single loose prism can be placed in front of the eye like this and to measure the angle of squint, and the prism bar as well can be used to measure the angle of squint. Here what we were talking about, the Fresnel prism. So what is the Fresnel prism? Fresnel prism is a plastic sheet of a small parallel prisms, small prisms adjacent to each other. They are identical in the refracting angle, so their overall effect will be equal to a single conventional prism. They can be adherent to the back of the glasses, so that the advantage of the Fresnel prism that it is cost effective and easy to use. So it can be clipped over the back of the normal glasses, and they are lightweight and they are flexible. But they have disadvantages, because the presence of series of small prisms in front of the eye will lead to decrease the quality of vision, and this is also asked in the MCQ exams. So it can cause glare, it can cause chromatic aberration, and it will decrease the visual acuity. So for what are the advantages? It's cost effective, easy to use, lightweight, so it is cosmetically appealing and flexible. So we can change it all the time. But their disadvantage is that it will degrade the visual acuity, so it can cause glare and chromatic aberration and visual decline. So here is an example for the Fresnel prism. As you can see here, different small prisms attached or adjacent together with the identical refractive angles, so they both act or they all act as a single prism. And this is Hillary Clinton. As you can see, she is used to wearing the Fresnel prism all the time. Other types of prisms is rotatory prisms, or what's called Riesle prism. So this the Riesle prism, meaning that we are joining two prisms together. Both these prisms are 15 prism diopters. They are joined together by a single frame, and there is a knob that this knob is a turning knob that can be rotated in different directions. So we can use this prism as a flexible prism if we want to have large power prism. So we put the apex of the first prism with in conjunction with the apex of the second prism. So we have about 30 prism diopter of overall power. If we want a zero effect, so we place the apex of this prism toward the base of the second prism, and the base of the first prism toward the apex of the second prism. So they will cancel each other, leading to a power of zero. If we want a power between 30 to 0, so we can rotate both prisms together until we reach the required prism diopter. So what is the functions of this Riesle prism or rotatory prism? It can be used to measure the very small angle of deviation, and can be also used like the double Maddox rod for measuring of the cyclotorsion. So this is the end of the second lecture. Thank you very much for your attention. Please, if you have any question in the prisms, please tell me in the chat box. If anything is not clear or you didn't understand, feel free to ask. Okay. So what is the question? Okay. Let's back to the hemianopia. So here is the image is always, as we said, will be toward the apex. So if we have a blind hemifield in both eyes, so and by placing the base toward the blind side, so the rays will be deviated toward the base, but the image and the eye will turn toward the other side or toward the apex. So the image will be directed toward the apex, which will be the seeing hemifield. The image will be toward the apex, which will be the seeing hemifield. So at any question, if you have any question in the prism, always repeat this sentence. This is the key sentence in the whole prism. The rays will be deviated toward the base, and the image and the eye will be deviated toward the apex. If you remember this sentence, you will find that everything in the prisms goes very logic. Does this answer your question? Okay, any other question? Well, this is a good question. So the question here is if the malingering test, if the eye is under the prism is blind, what will happen in the other eye? So this test cannot be done in case of the rule of this test is to place the prism in front of a seeing eye. If it is placed in front an actual blind eye, nothing will happen because the prism inside or the prism in front of the blind eye will not work or will not move. So this is also can be detecting that if there is patient has actual blindness or not. So if the patient can see, there should be a corrective movement. But if the patient show no movement at all, this means that this eye is blind. Let me repeat this again. If the right eye didn't show any movement, so this will be meaning that there is a right eye suppression. So it should be, or it must be, a movement of the eye in case of placement of the prism. If the eye didn't move, then the eye cannot see. And this is very easy test that to use for detection of the malingering or to detect that the patient cannot see. Is this clear? Okay, any other question? So your question, Dr. Safa, is asking about the other eye. So in case if the right eye is blind and cannot move, then the left eye will not move at all because the right eye didn't move. So the left eye is following the right eye. So there will be no movement at either the right eye or the left eye. The left eye will follow the right eye by hearing law of equal innervation. Okay, any other question? Okay, so no questions. So I guess that we reached the end of our lecture. I hope that you try to study this lecture as soon as possible because this is like I told you, it is like a backbone of the optics, like a base or a fundamental base for our discussions in the optics later on. Studying this lecture properly will make the optics easier for you later on.